Hello everyone. The topic for today's presentation will be testicular torsion. The following presentation was created by Alyssa Allen, Heather Davis, Deborah Goldman, Megan Main, and Haiti Waymeyer. The objective today will be to help providers understand the overall pathophysiology and epidemiology of testicular torsion. We will be discussing the clinical presentation, assessment findings, diagnostic criteria, and management for these patients. To begin, providers must know and understand that this diagnosis is a urological emergency that needs to be assessed promptly in order to prevent necrosis to the testes. This diagnosis can occur at any age. However, it is primarily seen between the ages of 10 and 20, with the peak amount of diagnosis made at the age of 14. Testicular torsions normally occur if the testis is not fixed to the tunica vaginalis, allowing for the spermatic cord to become twisted. The twisting of this cord cuts off the arterial and venous blood flow to the testicle, resulting in both ischemia and necrosis if interventions are not implemented promptly. The following is a great illustration that can be used to help providers remember the cause, clinical presentation, and required diagnostic imaging used in order to make this diagnosis. The clock in the corner is a great reminder that this diagnosis requires surgical intervention within 6 hours of onset. This medical emergency is usually idiopathic in nature. However, providers should understand that there are other initiating factors that can contribute to the diagnosis. These include the following. Anatomical predispositions account for approximately 40 to 80% of all testicular torsion diagnosis. The bell clapper deformity is the most common anatomical predisposition seen. This variation occurs when there is lack of normal fixation of the testes and the epididymis to the scrotum, which means that the testes can freely rotate within the tunica vaginalis. This type of deformity usually occurs bilaterally. Therefore, if the patient has the bell clapper deformity and is diagnosed with a testicular torsion, surgical repair to fixate the epididymis will be done bilaterally to prevent further torsions. Trauma is another initiating factor that accounts for approximately 20% of all testicular torsion diagnosis. Trauma to the testicle can cause the cremaster muscle to contract in the tunica vaginalis, leading the spermatic cord to become twisted. Other initiating factors include exercise, like bicycle riding and/or running, and family history. Patients with alterations in testosterone can also have initiating factors. Alterations in testosterone may occur during sex response and/or sleep cycles. During this time, contraction of the cremaster muscle occurs, leading to the spermatic cord to twist within the tunica vaginalis. The picture to the right has 3 different depictions. The first depiction on the left is a normal testis within the tunica vaginalis. In the middle, we can see the bell clapper deformity. In this picture, the testis is able to freely move within the tunica vaginalis. This often leads to the picture off to the right, which is a testicular torsion. In this picture, we can see that the testis is still freely moving within the tunica vaginalis. This has led to the spermatic cord to twist, cutting off both the venous and arterial blood supply to the testes. The clinical presentation of testicular torsion is very important to recognize due to the time constraint on treatment. Patients frequently present with an acute onset of severe unilateral pain that radiates to the inguinal region and abdomen. Patients may report a recent history of trauma or physical activity prior to the onset of these symptoms. They may also report associated nausea, vomiting, fever, and increased urinary frequency. The most common clinical sign found on assessment is testicular tenderness and the loss of the cremasteric reflex. Other objective findings may include an asymmetrical and elevated testis that has a transverse orientation rather than a longitudinal orientation, a firm and tender mass, and signs of scrotal edema, erythema, induration, and warmth. When assessing these patients, the provider will need to use the TWIST score, which has served as a successful screening tool for diagnosing testicular torsion based on both the history and physical presentation. The twist score assigns points based on the 5 following criteria: testy swelling, hard testy, absent cremasteric reflex, nausea and vomiting, and high riding testy. The provider will then add the patient's score up. If the patient scores 0 points, this indicates they are at low risk. If the patient scores between 1 and 5 points, it indicates they are at intermediate risk. If the patient scores between 6 and 7 points, it indicates they're at high risk for this diagnosis. Another assessment tool that can be useful is the manual rotation of the testy away from the midline. This is known as detorsion. If the patient reports relief of pain, it is likely indicating that this diagnosis is a testicular torsion. Providers should use the following diagnostic tests in order to confirm and/or rule out the diagnosis of a testicular torsion. Providers must include a urine analysis in order to rule out any type of infections. Providers will also want to include either a color Doppler ultrasound and/or a radioisotopic scan. Providers should know that a Doppler ultrasound is more rapidly available than a radioisotopic scan. They must also understand that any delay in imaging can extend the time of the testicular ischemia. Therefore, if patients present with positive physical findings of a testicular torsion, they should be referred for surgical exploration regardless of the ultrasound findings. This is because a negative surgical exploration is preferable to a misdiagnosis due to a false negative rate and/or delay in obtaining images. The following is an example of what the provider might see on the ultrasound. This shows a color Doppler scrotal ultrasound with decreased blood flow in the right testy. When patients present with unilateral testicular pain, providers should begin to build their list of differential diagnosis. They should, however, keep in the back of their mind that testicular torsion pain is often abrupt in onset and usually has no known cause. Their list of differential diagnosis should include diagnosis with common symptoms of swelling and pain in the testes. Providers will then perform specialized tests in order to confirm and/or rule out any of the differential diagnosis. The following lists of diagnoses have very subtle differences in the way they present. Some of these differential diagnoses that have similar symptoms to testicular torsions include intermittent torsion, epididymitis, testicular tumors, incarcerated inguinal hernias, idiopathic testicular infarctions, and scrotal abscesses. The provider should know that this diagnosis is a surgical emergency. Manual reduction of the testy is one management tool that can be done. Manual reduction of the testy is done with a gentle external rotation of the testy towards the thigh. This is because majority of testicular torsion cases occur with medial rotation away from the thigh. A successful reduction is indicated by relief of pain, resolution of the Bell-Clapper deformity, and restoration of arterial blood flow. If the torsion cannot be reduced manually, surgery must be performed within 6 hours after the onset of symptoms in order to preserve testicular function. If manual detorsion is successful, surgical fixation should be done within days to prevent reoccurrences. Surgery often involves untwisting of the spermatic cord and anchoring both testes in correct positions within the scrotum. This is demonstrated in the picture below. If the testicle is not viable, it will then be removed. This concludes our presentation on testicular torsion. If anybody has any further questions, please feel free to email any of the presenters and we will get back to you shortly with answers. We appreciate your time and thank you.